Okay, so on this slide, we're looking at a normal sinus rhythm. Remember, sinus rhythm was what you get to find between 60 and 100 beats per minute. But if it's outside of that range, then we have different words to describe that. We mentioned earlier how there's different waveforms. You get to P, Q, R, S, T, right? Then you have a delay, P, Q, R, S, T. Then a delay, P, Q, R, S, T. And if you look at, to determine whether this is normal or not, well, we want to count the waves. So you see P, Q, R, S, T, P, Q, R, S, T, P, Q, R, S, T. Like that looks normal, right? There's no abnormal waveforms there. It's not like any extra P's or multiple QRSs without, a P wave. So also we want to look for to determine whether this is normal is the distance between these peaks. So between the peak of the R wave here and this peak, and if you match these all up, do you guys think these look equivalent?
Yeah.
Yeah, it looks pretty regular, right? What this means then is that it's approximately, a fairly constant rhythm. So then we can say that this is a normal sinus rhythm, okay? Now, one thing I also want to check for to determine whether it's normal sinus rhythm, like a resting heart rate, is the beats per minute, okay? So how do you calculate beats per minute? Yep, count the number of these big squares and divide that number into 300. Good, so 1, 2, 3, and about 4. So 300 divided by 4? 75. You got it. Yeah. No, that's a hard one. Right? I've done this so many times, I just know it off the top of my head. You're right, 75 beats per minute. So that's normal sinus rhythm. So what's the P wave correlate with?
Atrial depolarization.
Nice. Atrial depolarization, right? Where does atrial repolarization occur?
In the middle of the QRS.
During QRS. And then what does a QRS wave represent? Ventricular depolarization. And then T? Ventricular repolarization. Good. And if you guys want to check out your EKG later, we can wheel them down and check it out. If you guys want to see your own EKG.
Mine looks funny.
Yeah? All right, let's hook you up. if you don't mind.
I have chronic tachycardia, so my waves are way close.
Oh, wow.
Are a lot closer.
Yeah. It's sometimes, if it's so close together, sometimes you get a P wave like on top of a T wave. So instead of having like the T wave totally relaxed, you might see the P wave just boop right there.
Yeah, they checked it out.
They can kind of stack.
But they're really close together.
Yeah, that'd be interesting. So earlier we were talking about, well, if our SA node fires at 100 beats per minute, why is it that like a normal resting heart rate isn't 100? Well, the heart's innervated, right? So it receives nerve supply from both sympathetic and parasympathetic nerves. Now, for the parasympathetic nervous system, we have the vagus nerves that come down the neck, cranial nerve number 10. Now, it also goes to the heart, and the vagus nerves go to the nodes. So the right vagus nerve goes to the SA node, left vagus nerve goes to the AV node, okay? We also have sympathetic nerves that connect to the heart muscle itself, and they can directly stimulate heart muscle contraction. And so sympathetic nerves can not only change the heart rate, but also the force of heart muscle contraction. Parasympathetic nerves can dampen down your heart rate, but it doesn't have much effect on the force of contraction. So mostly the parasympathetic nervous system just lowers your heart rate. Now, if you're resting, then you are more sympathetically active, right? So we talk about a resting heart rate. You're talking about what does your heart look like while you're more parasympathetically active? Well, if the effect of the parasympathetic nervous system is to slow down your heart rate, you should expect then at rest, your heart rate should be slower than 100 beats per minute, as it is for most people, right? So there's a lot of nerve plexuses that surround the heart, and we call these cardiac plexuses. And basically, it's just a lot of nerves that help supply nervous system information to the heart muscle itself. That way, you can alter your heart's contraction features. Like, you might not always want your heart to only beat at 100 beats per minute. Maybe you want it to go slower, even faster, right? So the way you can change that then is autonomic nervous system stimulation. So in green here, we have the parasympathetic nervous system. So we got the vagus nerves. There are branches of the vagus nerves that connect to the nodes directly. So the right vagus nerve goes to the SA node. The left vagus nerve goes to the AV node. And it can change the rate at which those nodes fire, action potentials. So if it's the vagus nerve, you're talking about rest and digest, you should expect then that the parasympathetic effect on the heart then is to slow down your heart rate. It won't really change the force of muscle contraction. It'll just make it beat more slowly, right? So if you're resting, then you should expect then that the parasympathetic nervous system, if it's functioning normally, should keep your resting heart rate lower than 100 beats per minute. What about the sympathetic nervous system? Well, we talked about how most sympathetic nervous system input comes from the sympathetic chain ganglia. We also have hormones like epinephrine, norepinephrine from the adrenal medulla, but there are sympathetic nerves. They leave the thoracic spinal cord, the synapse in this sympathetic chain ganglia, and then those can actually go out and then directly surround the outside of the heart and connect to heart muscle or these conduction pathways directly. Now, the effect of the sympathetic nervous system on the heart is that it makes it beat more quickly and more strongly. And it does this by altering how calcium flows into and out of those cells. If you can get calcium to flow into a muscle cell more quickly, then you get a faster contraction. And if you get it removed more quickly, then you get a faster relaxation, which means you can fit in more beats in there, right? So what the sympathetic nervous system does is it affects calcium regulation in the heart, and so it can actually get it to beat more strongly and more quickly. So those two kind of can go hand in hand with the sympathetic effect on the heart. And that can come from sympathetic nerves. But if someone had their sympathetic nervous system cut, like if these nerves were cut, your heart can still get sympathetic input, right? From hormones, epinephrine, norepinephrine. Yeah, in fact, one of the first experiments to determine like the existence of hormones was performed by this guy named Louis, and he actually had a heart in a nearby vessel. And in another vessel, which were linked up with a tube, he would drip in some secretions he found that were coming off of a heart. Like if you get a heart to beat really fast, you bathe it in like water, and you collect that water, which should have maybe hormones in it, right? Well, he added that solution back into the vessel that the other heart was at. And what he noticed is that when the molecules diffused over to the heart that was outside of a body and in that jar started beating more quickly. And so what he found then was the chemical correlate of heart rate. This is one of the first experiments to determine the existence of hormones. And you can't see these things. You just got to figure out, well, if I add a chemical, like, how's it going to change this hormone? Or is it going to change the effect of this organ? So that was kind of cool. But what this means, you guys, is there are backup plans. If the nerves of your heart get cut, you can still become more sympathetically active through epinephrine and norepinephrine. Yeah. It can take a little longer.
Had a lot of paraplegic patients paralyzed around the thoracic level.
Yeah.
Is that why their heart rate? We give them medication to increase their heart rate.
Mm-hmm.
Like they'll be down. I've seen them down in the low 30s. And we actually give them medication to bring them back.
Right. Exactly. So you're right with paraplegia or quadriplegia or just spinal cord injury. Depending on the site of injury, you can get a lot of autonomic dysfunction, like overly active parasympathetic nervous system or overly active sympathetic nervous system. In fact, one of the most life-threatening conditions with spinal cord injury is called autonomic dysreflexia, and they get these really strong sympathetic reflexes that start happening, and they can't control it, with the rest of their nervous system. So you get like these out-of-control reflexes where also their heart rate will skyrocket up to like 170 or more, and their blood pressure starts skyrocketing, and that can lead to fatal consequences. So yeah, it's interesting. So sympathetic innervation, you guys, comes from the thoracic spine. Remember, it activates beta-1 receptors in the heart. And these beta-1 receptors increase heart muscle contractility and rate. Different drugs like beta blockers, and if it's a beta-1 antagonist, would help slow down your heart rate, slow down the force of contraction. And it would make sense to give someone a beta blocker if they had high blood pressure, because heart rate or cardiac output, which correlates with heart rate, and blood pressure go hand in hand. So beta blockers can help prevent the sympathetic nervous system's effect on the heart. Now, these beta-1 receptors also respond to norepinephrine and epinephrine, so they're hormones that can stimulate a sympathetic effect. Norepinephrine is released from the nerve terminals of these sympathetic nerves, but you find norepinephrine and epinephrine both released from the adrenal medulla, and you're going to find them as hormones in the bloodstream as well. So your heart can receive input in both those regards. Now, we said how sympathetic input helps increase heart rate and the force of contraction. And the parasympathetic nervous system really relates to your cranial nerve number 10, or vagus nerve. It activates the muscarinic receptors in the heart, which are sensitive to acetylcholine, and this can decrease heart rate. Now, so it's kind of interesting. So parasympathetic nervous system innervation comes from the vagus nerve. Now, we mentioned earlier how there's different terms to describe like a heart rate greater than 100 beats per minute or less than 60 beats per minute. If it's greater than 100 beats per minute, we call it tachycardia. and that's an abnormally fast heart rate. And bradycardia is a heart rate slower than 60 beats per minute. They're not necessarily always pathophysiological conditions, but they're just terms to describe the resting heart rate of an individual. If your resting heart rate's 140, you just call that tachycardia. It doesn't mean there's like an underlying pathology, but it could be due to a pathology, or it could lead to a pathology. Like if your resting heart rate's too fast, it can lead to conditions like fibrillation, which we'll come back to later. Bradycardia, which is a slow heart rate, less than 60 beats per minute, this has to result in inadequate blood circulation, and this would be a condition where your heart's beating so slowly that you're not adequately getting blood supply to your body's tissues. Okay, and although you can actually have bradycardia as a result of like endurance training. So we learned earlier, someone in here has a resting heart rate of 41. Although that's bradycardia, because this person's an athlete, we wouldn't call this like a disease state, right? That's just a consequence of her training, if that makes sense.
We would
Yeah.
diagnose her with bradycardia that she has a resting.
You could call it bradycardia, but it's not a problem, right? It just means a resting heart rate less than 60, but it doesn't mean that it's causing heart failure, if that makes sense.
So normally we would just use these things to describe the problem.
Yes, yeah, exactly. Yeah.
My son had bradycardia in the NICU a lot.
Yeah.
Like, I don't know if it's just because he was too small to have all the blood flow, but he had bradycardia a lot. They didn't let him come home because of that.
Oh wow. Did they do anything for that?
They had him on a machine and just monitored him. There were a couple times that they had to actually intervene.
Yeah.
I didn't watch. We didn't know, but a lot of it happened when we weren't there. But he had to go so many days without having any kind of bradycardia symptoms before they went home.
Could be. All right, guys. So this next part's the cardiac cycle, and this is basically where we take everything we just learned about electrical activities and the mechanical events and just bring it all together to talk about what happens in one heartbeat. And it's phenomenal, all the things that occur just between one heartbeat. So there's two main states of the heart. We have a systolic phase and a diastolic phase. Systole just means a state of contraction. Diastole just means a state of relaxation. Okay. Now, what's important to note, you guys, is that your entire heart, bless you, your entire heart does not enter the systolic phase simultaneously. Right? The atria are in systole, while the ventricles are in diastole. Then the ventricles are in systole, while the atria are in diastole. And then all four chambers are eventually in diastole together. Okay. So it alternates. You go, systole, diastole, systole, diastole. And then they're both in diastole, right? Until you enter systole again, and then diastole, if that makes sense.
Is that where you get that long stretch before you hit your next P wave?
Yes, exactly.
That's the
Great point.
simultaneous resting of both.
Great point, exactly. So if you look at an EKG, you notice there's a big old delay between the T wave and the P wave, during rest. The reason why there's a delay is that during that period of time, the whole heart is in diastole. Everything's in rest, right? So the atria are filling, the ventricles are filling, and the heart's just resting. In fact, you spend most of your time in diastole versus systole. And when you calculate average blood pressure, you can't just take systolic pressure plus diastolic pressure and divide that by 2 to get an average. In fact, it's more like diastolic pressure times 2 plus the systolic pressure divided by 3. That gives you the correct average for your we call mean arterial pressure or blood pressure, because you spend 2 times as much time in diastole than you do systole. So it's kind of interesting. But systole, you guys, is just a state of contraction. Diastole is a state of relaxation. So if we talk about that systolic pressure, that's the pressure that's generated during systole. That's your highest blood pressure, right? Or we talk about diastolic pressure, that's the pressure that remains in your vessels while your heart is relaxed. You might wonder, well, why do you even have any pressure left behind in your blood vessels if your heart's relaxing, right? Like, how's there anything pressure at all? Why do you just drop back to 0? Well, what happens is some of your larger blood vessels can store some of that energy by stretching, and then while your heart's relaxed, the vessels will slowly start to recoil back down to a resting shape. And as they're recoiling, that's generating pressure. And that's your diastolic pressure. So diastolic pressure is actually due to the recoil of some of your larger arteries, which is actually pretty cool. So we're going to go through the phases of the cardiac cycle. The first phase we're going to start with, you guys, is ventricular filling. This occurs during diastole. Okay, so you have early and late diastole. If it's early diastole, what we're talking about then is the atria are still in diastole, the ventricles are still in diastole, but the ventricles are filling here because the AV valves are open, blood's pouring into the atrium, but because those AV valves are open, it's also going straight into the ventricle, right? So you got blood from the atrium going straight into the ventricle, and that's all starting to fill up, okay? Now, most of the blood that fills your ventricle is passive. It's not even actively pumped in the ventricle. 80% of the blood that fills your ventricle is due to passive filling, just due to gravity and pressure. Blood just ends up filling that ventricle. The additional 20% that fills your ventricle is actually due to contraction of the atria. So later on during ventricular diastole, which you're going to see atrial systole, atria contract, they force that little bit of 20% down to the ventricles. Now the ventricles are totally full. The amount of blood that fills your ventricles before they contract, we call end diastolic volume. And it makes sense because if it's at the end of diastole, that means it's right before systole begins. It's the volume of blood that's in that ventricle right at the end of diastole. So right before it contracts, how much blood's in there? And so it turns out that end diastolic volume correlates with how much blood your ventricle can even pump out, right? It makes sense. If it fills more, it'll pump out more. And so we call end diastolic volume preload, okay? So preload is the amount of blood that can fill your ventricle at rest. It also causes a degree of stretch on those ventricles, which in turn can make it contract more strongly. But we'll come back to that. That's called the Frank-Starling law. So during ventricular filling, you guys, while the atria are relaxing, can the ventricles fill while the atria are relaxed? Is that possible? Yeah, exactly. In fact, 80% of the blood that fills those ventricles occurs while the atria are actually relaxed, right? Yeah, while they're in diastole. 80% of that's passive. Only the additional 20% fills during atrial systole. So when the atria start contracting, they can force that additional little 20% in the ventricles, right? Right after atrial systole, then we enter ventricular systole, which would correlate with the QRS wave, right? So the ventricles start to contract. What happens next? Those AV valves close. Good. We're not there yet, though. We're still in ventricular filling. But one thing that's important to note, you guys, is EDV, end diastolic volume. We're going to talk about this a lot. A little bit today, even more so next week. End diastolic volume. Think about the name. End diastolic. So at the end of diastole. Now, with every end there's a beginning, right? So at the end of diastole, again, all philosophical.
No, I'm thinking of a song.
Oh, is there a song like that? Yeah, it sounds like that does sound like a lyric.
It's called
Uh,
Closing Time.
Oh yeah, I like that song. Yeah, Semisonic. Closing time.
I hope
Every new beginning comes from some other beginnings. And yeah, I know that one. I own that album. Come on, I'm a '90s kid. So, so at the end of diastole, right before systole, ventricular systole, end diastolic volume is the amount of blood that filled that ventricle. So that's important to note. Don't forget that, you guys. We're going to come back to that. Okay, I don't know. I got kind of weird there for a second. I know, it's fine. So now we enter then, you guys, right at the end of ventricular filling. Now we enter ventricular systole. All right, cool. So what's happening here? Well, while the ventricles are contracting, the atria are relaxing. We know this because during ventricular depolarization, we have atrial repolarization. So those occur simultaneously, right? Atria are relaxing while the ventricles are contracting. Now, if those atria are relaxing, that means pressure in the atria is lowering very dramatically. And this occurs at the same time while pressure in the ventricles is rising dramatically because the ventricles are starting to contract. So if pressure in the atria is low and pressure in the ventricles is high, and the ventricles are contracting, where does that blood want to flow? Back into the atria. But we have valves, right? The AV valve. So during rising ventricular pressure, the AV valves close, right and left. So the valves snap shut because blood's being forced up on the valves, right? Now, once those AV valves close, that causes a sound. Lub, S1, right? First heart sound. And because the ventricles haven't produced a whole lot of force yet, they've done enough to close the AV valves. Now we enter a phase called the isovolumetric contraction phase, where all the valves in the heart are closed, even though the heart is currently contracting. That makes sense. Isovolumetric contraction phase, all the valves are closed. You're not getting any changing volume of blood in the ventricles because it's not going anywhere because the valves are closed, and it's during contraction. But it's only the first beginning of ventricular systole. Eventually, the ventricles will produce enough force to open up those semilunar valves. When do the semilunar valves open?
When the pressure exceeds.
When the ventricular
The contraction pushes the blood out.
pushes the blood.
When the pressure in the ventricles exceeds the pressure in the pulmonary trunk and the aorta.
Nice. So when pressure in the ventricles exceeds pressure in the pulmonary trunk and aorta, then those semilunar valves pop open, right? Because then now blood wants to flow in that direction. And that begins during the ejection phase, which is later on in ventricular systole. And during the ejection phase, the semilunar valves are open and blood's being forced out, right? Now, near the end of systole, right? Near the end of ventricular contraction, what we end up with then, you guys, right before the ventricles start relaxing, now we have end systolic volume. And if it's the end of systole, what comes next? Diastole. Good. Now, end systolic volume is the volume of blood that remains in the ventricles at the end of systole. That makes sense, right? That's not a lot of blood, usually. It's a fairly small volume of blood, but there's still some that remains because your ventricles can't pump it all out, right? In order to pump out all the blood from the ventricle will have to squeeze entirely. Every single little nook and cranny in that ventricle will need to be squeezed, and you can't get it all, which means that right at the end of systole, there's still some blood that remains. So when it enters diastole, there's a little bit of residual blood in there, right? And that residual blood is just a tiny volume, but it's that leftover is important to understand then how much blood left the ventricle. So if you know your end diastolic volume, how much blood filled the ventricle, and you subtract that from end systolic volume, which is how much blood remains, then that gives you a value called stroke volume, which is the amount of blood that your ventricle ejected in one beat. Now that's important to note because that relates to blood pressure. We'll come back to that. So we'll come back to stroke volume. But end systolic volume, guys, just for now, know it's the amount of blood that remains in your ventricle at the end of systole. All right. Now, if it's ventricular systole, what's going on in the atria during this period of time? Well,
Relaxation.
yeah, their atria are resting, maybe even starting to fill a little bit, right? So, what should happen after ventricular systole then? What phase do we enter next? Well, we start to enter diastole. Now, the ventricles are in diastole, the atria are in diastole. Everything's in diastole, right? So we're at rest. So now we're in a relaxation phase here. Now, once the ventricles start to relax, what happens to pressure in those ventricles? Decreasing, right? Now, you're going to have a period of time when the ventricles are relaxed to a point and pressure is so low in the ventricle that's now lower than it is in the aorta and pulmonary trunk. And when that happens, blood in the aorta and pulmonary trunk want to flow back into the ventricle. But the semilunar valves catch it, they snap shut, and when those semilunar valves snap shut, that begins the isovolumetric relaxation phase, which is S2, when the semilunar valves close, but it's a brief period of time when all of the valves are again closed. AV valves are closed because pressure in the ventricles is still too high to get those valves to open up, right? And the semilunar valves are now closed because the pressure in the ventricle is actually lower than the aorta and pulmonary trunk, so that the semilunar valves snap shut. So during the isovolumetric relaxation phase, AV valves and semilunar valves are all closed. Okay? It's a brief period of time though, because the ventricles continue to relax, and once they relax enough, eventually the AV valves will swing back open, right? So when will those AV valves open up while the ventricles are relaxing?
When the pressure of the ventricles greater than
The other way. You're close.
The atria exceeds the pressure of the ventricles.
Because it when it flows down.
Yep, exactly. So those AV valves won't open up again until the ventricles are relaxed so much that pressure in the atria is greater than pressure in the ventricles. You can imagine it's got to be a lot of relaxation, right? Because there's not a whole lot of atrial pressure. Like venous pressure is super low. when you start talking about the blood pressure you find like in your superior and inferior vena cava, it's close to 0. So what this means is the ventricles almost have to completely relax before those AV valves even swing open. Once they swing open, guess what, you guys? Now we just went full circle because now we're back to ventricular filling. Remember? And then the first 80% of that ventricular filling is passive. So what caused those AV valves to swing open again?
Atrial filling.
You got it. Pressure in the atria is lower than the pressure in the ventricles.
Exceeds.
Pressure in the atria is higher than pressure in the ventricles. I'm sorry. So yeah, I know. Thank you. So pressure in the atria then, is that due to the contraction?
No.
What's that pressure from?
Gravity.
Gravity's part
It's the blood volume in it.
and the blood that's starting to fill the atria. That generates a little bit of pressure.
Stepping on the trap.
Yeah, it's like stepping on a trap door. You got it. I love that example. Just stepping on a trap door. That eventually opens up the trap door. What if someone's holding that trap door? Well, if you get enough people to step on the trap door and that one person can't hold it up anymore, maybe the whole thing falls open, right? And then everyone falls in. But it's still passive, right? So the first 80% of filling is passive filling. It's not even occurring during systole. It's occurring diastole. Now we just went full circle. Now there's one thing I forgot to mention on the slide, you guys. The dicrotic notch occurs when these semilunar valves close, and it's a little blip in pressure you can see with a very precise blood pressure reading, and you actually can feel that. You can measure this peripherally. Like if you measure blood pressure, like in a brachial artery or like radial artery, you can see what's called a dicrotic notch, and it's a little wave of pressure that gets sent out. And it's actually generated when the semilunar valves close. Those semilunar valves close with so much force, it creates a wave of pressure that spreads throughout your arteries. We call it the dicrotic notch. Okay?
A wave of positive pressure or negative
Positive pressure.
pressure? So it's like a little jump on your sphygmometer.
Yeah, you
like
got
a
it.
random little
Very,
jump.
very small. Like you're not really going to see it much with a sphygmometer, but you're going to see it better with like an intra-arterial catheter, like a recording. I'll show you guys that data pretty soon. That's the cardiac cycle. So let's go through that pictorially then, because I did a whole lot of like pantomiming up here with like my arms and stuff. So let's just go look at some pictures now. Okay, so let's start here, guys, with ventricular systole, not ventricular filling. Okay. Now that we're going to start at a different point. We're going to start while the ventricles are starting to contract. So this is after filling. So what's the volume of blood that fills the ventricles right at the end of diastole? End diastolic volume, right? Exactly. And that blood came from the atria, right? Why are the AV valves closed here? Good. Pressure in the ventricles is starting to push up on these valves, which causes the valves to close. But the reason why blood wants to flow back in the atria is that the pressure is lower there, right? But due to the nature of these valves, the valves close, which you can see down here. So you can see the AV valves are closed. Now, this must be later in ventricular systole because our semilunar valves are already open, right? So when do these semilunar valves open up? Awesome, very good. When pressure in the pulmonary trunk is lower than pressure in the ventricle, that's when blood can leave the ventricle and enter the pulmonary trunk. Same for the aorta. If pressure in the aorta is lower than ventricular pressure, blood's going to be allowed to flow. That's when those semilunar valves swing open, right? And that's the beginning of the ejection phase. So right when those semilunar valves open, that begins the ejection phase where blood's actually ejected from the heart. What's it called when all the valves are closed but the ventricles are contracting?
Isovolumetric.
Nice, good. Isovolumetric contraction phase. Awesome. So that's not what this is showing though, because the semilunar valves are open here, right? So, oh wait, hold on. Semilunar valves are closed now. Yeah. So now the ventricles have entered diastole or relaxation, right? So our semilunar valves closed while the ventricles are relaxed or relaxing. Why do these semilunar valves close again? Backflow, right? I guess and you could be more precise and say that blood wants to flow in the ventricle because pressure is higher in the aorta or pulmonary trunk versus the ventricles now because the ventricles are relaxing, right? Which is what closes those semilunar valves. But these AV valves are already open, so this must be later in ventricular diastole. Because remember, when you first enter ventricular diastole, all the valves are closed. Exactly. So this must be later in ventricular diastole. So what opens up these AV valves?
Pressure from the atria. From your three leading in.
Pressure in the atria is
Higher.
higher than the ventricles. Good. Now, it's not because the atria are contracting, like you were saying. It's because the veins are now draining blood in the atria, and the pressure is slowly rising. It's not a lot, you guys. It's enough to get the valves to open. And the heart's relaxed here, so we know that the atria aren't even contracting. So these valves open up in a passive manner, but it's due to a pressure difference between the atria and ventricles, right? So that most of the filling here that in the ventricles is actually in this phase here during ventricular diastole and atrial diastole. 80% of the blood that fills that ventricle is passive, not even active, right? And then this is showing full circle. So you can pick a point. Let's say atrial systole. So atria are contracting. How much blood do they pump in the ventricles? 20. Yeah. Only the remaining 20% of EDV comes from atrial systole. 80% of EDV comes from passive filling. So if the atria are contracting here, they're only pumping the residual 20% of the volume of blood that fills this ventricle, right? It's not a whole lot. Right after atrial systole, then we enter ventricular systole. That makes sense because looking at the EKG, we had a P wave, which was atrial depolarization. That's going to correlate with atrial systole. Then, right after that, we had a delay. Then we had our QRS wave, which correlates with ventricular depolarization. So it makes sense the next phase then would be ventricular systole, right? Now, early on in ventricular systole, while the ventricles are contracting, it causes these AV valves to close because blood's being forced up on the valve, right? And the blood wants to flow back in the atria because pressure is lower in the atria, right? But these AV valves prevent that backflow. And it's basically blood pushing up on the valve that causes it to shut. That causes a sound, which is S1, aka lub. Good. All right. So during this same period of time, the atria are also in diastole or relaxing. Now later on actually I'm sorry, let's one more thing, you guys. All the valves are closed here. So semilunar valves are closed, AV valves are closed. What phase is this? Early ventricular systole, which correlates with? Nice. Isovolumetric contraction phase. Because all of our valves are still closed, even though the ventricles are contracting. Then, later on in ventricular systole, once the ventricles can generate enough pressure to overcome the diastolic pressure in your aorta and pulmonary trunk, then you can have the blood be ejected. That's the ejection phase, which opens up these semilunar valves because now there's more pressure in the ventricles to overcome the pressure in the pulmonary trunk and aorta. I'll tell you what, guys, ejection phase is pretty short. It's not even that long. You know, it's a long enough time to get some blood out of your heart, but it's it's more of a briefer period of time of ventricular systole. A lot of ventricular systole is isovolumetric contraction phase, where the ventricles still haven't even generated enough pressure to overcome your diastolic pressure. So why would this mean that having a diastolic pressure that's high is not a good thing? Like, if someone's diastolic pressure is 120 instead of 80, like, why would that be a bad thing? Right, you don't want that high of a pressure. But with respect to the heart, though, what's that doing to the heart? Yeah. You got it. If your diastolic pressure, you guys, is like, let's say 130, why not? Okay, and where it should be normally by 80. That means your ventricles, like you're saying, have to contract even more strongly just to get those semilunar valves to open. Which means ejection phase is shorter, which means your heart has to work even harder just to pump blood, right? Because it has to overcome that diastolic pressure. But we need diastolic pressure to keep blood flowing. If you didn't have a diastolic pressure, then blood would stop flowing, right? Blood only flows from high and low pressure. So there's a good middle ground between too much pressure and no pressure. That's why we have a diastolic pressure. We'll go back to that later. That's next week, okay? But this is also why having a really high diastolic pressure is not a good thing, okay? Now, during the ejection phase, then blood's actually forced out of the ventricles to the aorta and pulmonary trunk. Once the ventricles enter diastole, why do these semilunar valves close? Good. Good. Pressure is higher in the aorta and pulmonary trunk and lower in the ventricles because they're starting to relax, which means blood wants to flow back, but the semilunar valves prevent that backflow, right? During the same period of time, the atria are filling, right? And so pressure is now rising in the atria. However, there's still some pressure in the ventricles early in ventricular diastole. Not enough to get those AV valves to open. But once ventricular pressure is lower than atrial pressure, AV valves swing open and you get ventricular filling, which is passive. So the early phase of ventricular filling is actually a passive process, not even during systole. Everything's in diastole at the moment. And guess what, you guys? That's the cardiac cycle.